Good afternoon. Welcome to session E3. I don't know if you are looking at the program. This is what it reads. Learning from Failures, Pierre Barker, Bruce Agins, and Rashad Massoud. I don't know if that was intentional or not, but we will be talking about failures, but I don't know that they've listed them in the right way. Anyway, welcome to session E3. My name's Rashad Massoud, and delighted to be with you today to have a really honest conversation about things that we've done, things that have not worked. Most of the time we talk about the great experiences we've had, the successes, and this session is of a different nature. What we'd like to talk about are things that didn't work. We've prepared a story each that we will tell you about things that we've tried personally that have not worked. And what we'd like to do is really give you the opportunity as well to share with us your experiences about what hasn't worked for you. So with that, we'll start the session, and my colleagues will also introduce themselves.
Good afternoon. I'm Bruce Agins. I'm the Director of Health Quality International and work at the New York State Department of Health.
And hello, my name is Pierre Barker. I'm Senior Vice President at IHI, responsible for our work in low and middle income countries. And I think it's me first. Okay. So I think we really appreciate you coming along this afternoon, particularly as the exact topics that we're going to be speaking about are a little opaque. But we're hoping that we will be able to engage you in a discussion about some of the things that we've tried and that we've run into some difficulties with. My topic is how to design, or maybe not, a large-scale QI research project in a complex environment. And I'm going to talk with you about two projects that we undertook, one in Malawi and the other one in South Africa. And I'll tell you a story about both of them. So the first one is about Malawi. Malawi has a population of 13 million. And the problem in Malawi is very high maternal mortality rate of around 350 per 100,000. When we started the project, in fact, we thought that it was very much higher, around about 800 per 100,000. To give you some context, in the USA, maternal mortality is close to about 10 per 100,000. Neonatal mortality is around 30 per 1,000, and again, you can see a comparison about what it could be in a high-income country. We're working in 3 districts, and the aim of the project was to test methods to reduce maternal and neonatal mortality by 30% in these 3 districts over a 5-year period. The design was a cluster randomized control trial that was testing 2 interventions. One was a facility-based intervention which used a straightforward quality improvement approach, and the other was a women's group action cycle intervention which was held in the communities. We had 3 partners involved: Women and Children's First, the Institute for the Women and Children's First, who were technical advisors for the women's groups in the community, the Institute for Child Health, who were the evaluators, IHI, which provided technical support for the quality improvement, and the project was funded by the Health Foundation. So I'll just very briefly take you through the cluster randomized design. So here is a representative district which has 22 health centers and surrounding communities. The health centers represented by the dark blue dots with their communities surrounding them. The health centers were the primary randomization unit for the intervention, and you can see though that they were cluster randomized according to the dark dots for the QI intervention, and half of them received no QI intervention. There was a further randomization which was for the community activities, and you can see that we had 4 possibilities. The one was a health center intervention only, a community center intervention only, or you could have both, community and health center intervention, or you could have neither, no intervention. Those were the groups that were under study. So here's where things get just a little bit complicated, because there were, on average, 2 or 3 district hospitals in these districts, and each of these district hospitals had a constituent number of health centers that referred into those district hospitals. And of course, the district was overseen by a district office which had a program on maternal child health, which we were following particularly in the community interventions. So what were the problems? So this is a randomized controlled study which had a specific question. Is a facility intervention better than a community intervention, or is a community intervention better than the facility intervention? Are both together better than one alone, or do neither of them make any difference? And that was the question. The problem in a randomized controlled trial is that you really need to make sure that your interventions are separated, and that there are no extraneous variables that might affect your result. The biggest problem that we encountered immediately was one of contamination. And this is the kind of thing that you might expect in a complex system that in fact this is a real life environment, a health community that is administered and managed by a district office. The district office were impressed with the improved use of partographs, and they immediately, which was one of the specific facility interventions that was engaged, and one district in particular, they immediately spread those changes to all the health centers, which included the controls. Another district hospital was really impressed with what they saw going on in the community, with the community groups. They went out and in fact found their own funding to make sure that every community that they had control over received the community intervention. One other district hospital spread the checklists. We had a referral checklist to ensure that mothers were effectively referred from the health community, the health centers, to the referral hospitals, and likewise they wanted to spread, and so on and so on. So you can get the sense here that there is, because the district office has control quite correctly about what interventions they want to see executed in their own district, they're going to move things exactly as they fit, and appropriately not pay too much attention to what's going on with the design of our project. But I think that there were some other issues that came up that I think were in a sense even more concerning to us. And one of the most disheartening parts of this project was to see disengagement and disillusionment that came from a kind of a loss of belief in the project as these district managers encountered resistance to change that they wanted to engage in. They couldn't understand how some of the very high and needy health centers were left out because of the randomization. They felt that this was a waste of resources, and they were frustrated that interventions that clearly were designed to be together, the community and the facility interventions, were not brought together because of the restrictions of the design. This created tensions within the team itself. There were some variations, particularly in the community design, that the team wanted to change because they felt that these were innovations that were being suggested by the villagers, and they were not able to do that because it didn't conform to the model that was being used. And there was increasing discord between the partners, some who were arguing for relaxation of the trial rules and others who wanted to stick very closely to them. So you can see a sort of not a very happy situation. So, however, I would say that we did stick to the design. The design was conducted over a 4-year period, and at the end of the randomization period, which in fact happened in December, there were a number of changes which were immediately put in place. The first was to be able to work much closer with the district health management team and the zone, the regional office, who are working over the whole district. We did a Pareto analysis of volume in each of the health centers, and the emphasis was switched to the high volume units where we felt we could make the most impact. The hospitals had freedom to support whichever health centers they wanted, and we started introducing innovation at the community level, which we'd not been able to do before. And now to deal with the issue of a control group, we have a plan to collect data from adjoining districts to compare the performance, since we no longer have a randomized control unit to be able to do that. I think the jury is still out as to really whether this in fact was a failure, because we don't have the results of the evaluation. And I think there are several benefits to the redesign that we're anticipating. First of all, that the project, which now has a lot of buy-in at the district level, will get the attention of the region and the nation, and will become a true implementation project as opposed to a strictly a research project. The team has come together, the partners have come together, and there's a major change in the work environment with motivated and activated teams. I wanted to briefly talk about the second case, a shorter story really about a project that we're undertaking in South Africa. So our partner in this was the University of KwaZulu-Natal and the 20,000 plus team. Some of the team members are attending this conference. This was a project to decrease the transmission of HIV from mother to infant in a 3-district population of about 5 million people. We were testing, this was slightly different to the Malawi project which I just described. It's testing purely QI interventions. So we're testing on the one hand whether individual QI support to the clinics is better than QI support alone plus a breakthrough series network that brings these clinics together. And again, it had a cluster randomized design. I'm not going to dwell too long on all the things that happened, but I can say that the kinds of problems that we ran into were very similar to the kinds of problems that we ran into Malawi, and they were mainly around the lack of design flexibility that allowed us to introduce innovations in a fast-moving way. One of the biggest issues was hospitals that came to us and said, we love this methodology, we want to form our own breakthrough series collaborative with surrounding hospitals. And we were saying, well, we can't help you with that because those clinics are in fact not randomized into our unit. We steadily lost the support of the district management team, which we'd spent a lot of effort up front trying to gain. And the team, in fact, started the implementation team started to really, there were tremendous tensions as a result of this because they felt that we were putting research ahead of implementation. And so the number of changes were made at the time, and in fact one of the interesting aspects about this project is that there was a data safety management board, monitoring board, that was reviewing our progress, and they in fact asked us to stop the trial because they felt that the integrity of the research design had been compromised. And I think, whereas we don't yet have the results from the Malawi evaluation, I think that we do have some interesting results from South Africa that would support our concerns about the effect that the randomized control trial had on the results. And here on the left-hand panel are results of testing. On the blue line are mothers turning up for testing, and the red line is the mothers who were actually tested. And you can see that right from the beginning there was a close correlation of the two lines. But what was clear that after the project launched, using the randomized control format, there was in fact a spike in testing rates going up. You may not be able to see, from about 70% to about 80% of the mothers being successfully tested, but that after a while that rate in fact went back down again. After the project was redesigned and we allowed a much more free-flowing quality improvement design, the results in fact showed a significant sustained increase in the rate of testing, which was continued throughout the period. And what you can see on the right-hand side was our primary outcome, which was mother-to-child transmission rates. You can see the project was launched in February 2008. I don't think that we can claim a direct correlation between the intervention and the results, because we were at that stage only covering a relatively small part of the district. But we do believe that bringing the project together and being able to accelerate rapidly through the districts, that contributed significantly to the rates of fall in transmission rates that you see in the right-hand panel. So I think the questions that we have are really, is it possible to run a quality improvement randomized controlled trial within one of these districts where the district management runs activities over the whole district? In other words, the district management is truly in control of the intervention and the implementation, and it's really very difficult to under those circumstances to keep the environment constant, which is what you need for a randomized controlled trial. One of the biggest tensions came where we were not able to take account of natural referral units in the trial. In other words, our randomization did not pay attention to the natural referral relationships between hospitals, health centers, and the communities. There's an important question: is it ethical to try to stop the spread of innovation in a district when you've got clear evidence that something is working on a local level? And are there better ways to design these studies? And I'm sure there are. We certainly know of alternative ways to study in a controlled way complex environments. I think there are a couple of other questions, which is that we may have to overpower studies in order to be able to, if we really want to do randomized controlled trials, we may have to overpower studies in order to be able to get a positive result. There's a big danger, I think, that if you get a negative result, that you may be missing some important learning, that the negative result may not be a true reflection of the improvement. And then there's a further question, I think, which is maybe randomized control trials, if you can get the result that you believe in, are good for proof of concept, but they really are not the best method for improvement. So those are the questions that I think we were grappling with as a result of this. As a result of this experience, I don't want you to go away with me having created an impression that I have persuaded you that randomized controlled trials should not be used for quality improvement research. But I think that if we are designing using a randomized control evaluation design, then I think we should be very aware of the kinds of problems that both of these projects ran into, and adapt and design accordingly. Thank you. So I'm very happy to take any questions or any comments from the audience.
Peter Davey from Dundee. So you mentioned step wedge design, which I think does get around some of the problems anyway that you've mentioned. And actually, sometimes I think there's a nice study from Holland in ICUs where there were 3 different sort of practices of care going on in different units around Holland, but none of which had been compared, and they persuaded the ethics committee that it would be more systematic to actually test each of those 3 things in the same ICUs in a different sequence over a period of time. So they would sort of try each model of care. So each ICU would try each model of care.
Yes.
And that way they didn't even have to get consent to, because the argument was, we don't know, these are all being used, we don't know which one is the best.
Yes.
So I think those sort of more pragmatic designs do have quite a lot going for them.
Yes.
I would agree. I mean, and we are in fact now using the stepped wedge design. So stepped wedge design is where you take a wedge of the system, which I think would be a representative unit, and based on this experience would include a natural unit, such as a referral unit, and that you would get to the entire area that you're looking at. You would start with one part of the system, and then you would move on to the other, and the other parts of the system that you hadn't started with would be your control areas. The problem again with that is if the administrative control of that whole unit lies with somebody else, you do not have the ability to make to control those other areas in terms of the spread of interventions. You're still going to run into problems. And I think your second comment, which is to describe other ways of approaching this, I think are really important. I think there is a science, and Lloyd Provost is our expert on a number of alternative designs, particularly factorial approaches, where if you have 5 or 6 units, you can simultaneously, instead of leaving some of the units out, you work in all of the units, but you bring the changes, different combinations of changes to those units at different times, making sure that everyone... And I think under those circumstances, you can probably get enough buy-in, say if the district manager is in control, and with enough explanation, you could probably run a trial like that without having the problems of diffusion of innovation. And just saying you want to stop diffusion of innovation is really problematic to me, although I think, we are really trying to learn whether some of these interventions truly do work. And so one could argue that the effort that goes into designing rigorous studies to really prove that your intervention is better than no intervention, I think is really important.
Dale Webb from the Health Foundation. I'm over back here. Hi, Pierre. Thanks for the presentation. I think there are very honourably held views on both sides of the debate about the role of RCTs in evaluating complex interventions. I commissioned the evaluation, so I hold a differing view, and you and I have kind of shared those views before. I think the Malawi programme was asking the question, if you only work in health facilities, or if you only work in communities to improve health, is that less or more effective than trying to do both at the same time? And I think that's a very powerful question that's seldom been asked in the developing world. And, the results are being verified. You and I have seen them, but maybe it was a hypothesis that actually was worth testing, because the power of that evidence for the international community, the global community, in designing interventions like this, I think will be very, very persuasive. Yes, there are problems in trying to maintain an RCT design for a 3, 4, 5-year period, and you describe those really, really nicely. When we say, though, is there clear evidence that it works at local level that should allow spread, as you know, in the Malawi programme, the evidence we've had at local level has been quite patchy and inconsistent, and actually I think if we'd allowed innovation of some of the ideas in the early stages, we might have made some mistakes along the way. So I think there are practical problems to resolving an RCT design in complex interventions, but I think the principle, if the standard of evidence you want is so significant to answer these big questions, I think it's a method that's worth persevering with.
Yeah, I think the issue of the power of the the design to actually show a result is one of the major things that I took away from this, which is that you cannot assume. First of all, you have to ensure that the dose that you designed is actually delivered. And then secondly, I think that if you are working in a complex environment where you don't have control over the implementation of, and particularly the spread of innovation, that I think you are going to have to adjust your power calculations accordingly to make sure that you're overdosing, because you may well miss a positive result as a result of that.
Many congratulations for being brave and honest enough to give such an interesting presentation. Best I've heard in the forum for a long time. My question is that in simple randomized controlled trials of one drug treatment versus another, or drug treatment against placebo, the clinicians and the patients have to have equipoise about whether or not the treatment is going to be of benefit or of disbenefit. And equipoise is clearly very important. And listening to you, it became clear that many of your participants didn't have equipoise about the value of a quality improvement intervention. And it strikes me that that was the fundamental problem, was that the district administrators did not have equipoise. So thinking through that, how would you learn from that to get better equipoise between the two interventions of a future trial, however you designed it?
Yeah, I'm not sure whether I would agree that there was a lack of confidence in the methodology. I think that there was anxiety about the way in which I think equity came to the fore as one of the major concerns, that we were working in some areas of the district in an apparently random, not apparently, but truly random way, and that we were not taking account of the so-called needs of the particular participants. I think that so the district managers saw this as not part of their job. They just felt that we were messing with their responsibility to get care to the people who needed it when they needed it. I think there was another disruption within the team. The team felt that they were being asked to, well, in the South African case I'll speak to mostly, that they were being asked to push a kind of an unnatural intervention, and that they were not being able to respond to the direct requests that they were getting from people who they needed to form very good and close relationships with in order to be able to execute the project. And they felt that they were not able to continue to keep the trust of those people, of the hospital staff, because the hospital staff were asking for their help to do something that they saw huge value. It was almost the opposite. They saw huge value in them. Okay, I'm being told that our time is up, so thank you very much.
Hey, good afternoon. I'm going to shift gears a little bit here and talk about an experience that we had in our routine measurement system and our performance measurement system as we were working in Kenya. So this is a case study about implementing performance measurement. So just really quickly, I think we all know this, but to frame why this is so critical for us, that we focus on routine performance measurement in our work with other countries, to separate what we think is happening from what's really happening, to get a baseline, to help us avoid putting ineffective solutions into place, to monitor our improvements and prevent slippage over time, to learn whether or not the changes that we're making lead to improvement, and to have some kind of standardized system so that we can compare what's happening across the sites that are working. So I'm going to give you a little bit of context that will then, I think, give you a little bit better sense of how to understand our specific case. We have a TA initiative, and we're working in 10 different countries as Health Qual, based on a model that we developed back in the United States with a methodology that's been successful since 1996 in New York State, that's been adapted for work in HIV ambulatory care programs in the U.S., and was adapted for use in Thailand in 2003, and then spread through 6 other PEPFAR countries that we've been working in over the past 5 years. What we do is we ask the facilities to generate an active case list of their patients and define an eligibility criterion, which is usually a certain number of visits over a time frame. And then we employ a simple randomized sampling methodology to select charts for review. And this is either done through an automatic randomizer that they have, or it's done by someone for them that then tells them which charts to review. And there's another strategy which I'll show you in a minute, but those sample sizes are calculated to give us a level of confidence and precision to achieve reliable data that can be used for different purposes. And we usually calculate that to reach 95% confidence intervals with a spread of 8% in either direction. So in addition to a randomized approach, we can also use a stratified sequential sampling model, which would just simply be calculated in any kind of setting by taking the number of patients and dividing by the intended sample size, and then using the resulting number as a sequential N for picking the charts from the list. When we look at the overall flow of our process, this is divided into 2 halves. On the left, you see for the routine paper-based system, and we do have some sites in one country where an electronic medical record is used. And that's actually in a resource-limited setting in Haiti, which you can hear about tomorrow at a different session. And in this situation, once the case list is generated and the sample number is created, the charts are pulled, the data are abstracted, data are entered either into a paper-based system and then into a simple software program or directly into the software program. The data are analyzed and the results are communicated and used. So just a very basic, straightforward process. Now, the question I think that comes up is, well, what do we use these data for? And so we've looked at this table as a way of identifying different purposes of data that may be captured as a part of routine performance measurement. So they can be used for choosing a QI activity, conducting a QI project, assessing change over time, comparing performances across clinics, aggregating that data into a national report. And then I think as we continuously talk about, how do we make these data translated into a formal evaluation or a publication so that they can get into the literature and we can learn about effective changes. Here's a simple graphic about how the case list is created. I think just to make it very clear, again, very simple, that as you go around the circle going in a clockwise direction, if you've identified the patient population in your clinic, you want to eliminate those, in this case 3, that don't meet your eligibility criteria. Then we may find that those that met eligibility criteria have either died or transferred out or relocated, and then we come up with the accurate case list for sampling. So again, very simple and straightforward to move forward. Okay, so that's the general approach. I'm going to tell you about the specific example that happened when we started working in Kenya 2 years ago, and I should also say up front that our Kenya team was very happy to agree to share their story and hopefully and believe that it will hopefully contribute to learning going forward. Our Kenya program is that we work with a team that's based in the Ministry of Health and the AIDS program, NASCOP, that's staffed by 1 program manager and 1 data manager. That also involves some technical advisors that are based in the ministry, clinicians in the ministry, and a QI coach who's part of our US-based team that comes into country and provides guidance. A technical working group was developed in 2009 to develop the indicators that were used, and this was a package of 6 standard ambulatory care measures. And they decided on their own to focus on adult, pediatric, and PMTCT services at the same time. And they were looking at performance in 15 sites spread across 3 districts. And the data collection was completed at the end of 2010. So there were two different methods for training the clinic teams. One was that we conducted some group trainings, and there were 3 providers from each facility, a clinician, a nurse, and a data manager, who came for a 2-day training. We had hoped to include the PMTCT and the pediatric, the maternal child health staff, but they weren't able to travel because of budget limitations. Somebody from the National Technical Working Group attended, and representatives from the ministry as well. And the sessions are very practical. People get a chance to actually go through the process. They have some examples from which they can go through the sampling and the data abstraction, and that's, again, part of the group training. And then the specific methodology for Kenya, and I just show this to you to see the added complexity of the different, which is represented by the different colors, where they needed to get separate samples for adults, children, and pregnant women. And so again, that really added several layers of complexity to the process. Then in the second method, there was coaching on-site to each of the clinics, and this included some phone calls during the data collection process, followed up with site visits that included members from the national team and from the CDC staff in Kenya. And they had a supervision checklist form that they used to further guide the process. Here's just a quick shot of the tools. There's a data abstraction tool on the left and the supervision checklist on the right. So what went wrong in Kenya? Well, one of the first things, which probably comes as no surprise, is that the clinic teams tried to combine their patient lists from the adult population, the pediatric population, and their antenatal care patients. As we often hear, people are busy seeing patients with few staff, and they felt that they just didn't have enough time to enter data. And similarly, they didn't have time to really pay attention to the methodology. And then furthermore, the actual information systems that they use in the clinic didn't really allow them to accurately generate case lists because they didn't really have an easy way to track pregnant women in the adult clinic, and there was no way to also track exposed infants. And then the data were sent in, as usually happens, and a number of things were observed. So among them was that we didn't find that the actual numbers of case lists were reported. So this meant that there was really no way to assess whether the actual number of charts reviewed was sufficient to achieve the intended levels of confidence and precision that could be used for benchmarking and to meet the goals of the ministry to look at the quality of care across this particular clinic cohort. And the in-country team was then asked to go back and try to collect caseloads to see whether or not the sample sizes had indeed been adequate. And I think, again, just to show you the simple pictorial here, is that the combination of the patient populations, particularly the pregnant women and the adults, didn't really allow for adequate sample sizes. I think I've talked about the inability to achieve an accurate case list, and then also there was skipping of this test, of the step to have the different populations. So the next thing that we did was, after this was over, is we stepped back and looked at the overall process to see if we could identify other things that we could have done differently. And one of the first things that we identified was that there was a knowledge gap. We felt that the instructions had not been sufficiently detailed, that the methods that had been successful in the other countries could not just simply be adapted to the Kenyan context. That there had been a long period of time between the training and the time of implementation, and that the people in the field and even our management team didn't fully understand how the data could be used and why the methodology was important for different purposes, and so therefore the integrity of the methodology was compromised. And I think, as I've mentioned, there were some information systems issues which are common in many settings. In this case specifically, that pregnant women were not separated from non-pregnant individuals, and the exposed infants were not identified. And then, as the team prepared their report, which needed to be submitted to CDC, they prepared a report that really didn't include a discussion about these methodologic issues. There was an additional knowledge gap there about how to develop the report. There hadn't been any adjustments made for the denominator sizes, and there clearly had not been a process for verification and data quality checks, and there had been no process for documenting the process to go back and see what happened. Then the CDC and the ministry team asked the team to redo the report and revise the report. Essentially, they would not accept the report as it stood, and so extensive revisions were required. And then we came in and provided some additional support to go back and conduct the process investigation that I just described and reassess the data and its usefulness. And a lot of the discussion revolved around the different uses of the data that were being collected. So again, this is routine performance data, but used for many different purposes to look at quality at different levels. So I thought I would stop here for a quick moment and ask you what you would do if you found yourself in this situation where the data report came in with this sort of information. How would you use it? And I think one of the things that I didn't describe, and I'm sure pertains to Pierre's example as well, is that there's a tremendous amount of investment and time spent by the people involved in the process, and so a sense of wanting to move forward with what they've done. And so we really had to make some decisions about what we could do, what made sense, and what worked. So I think the first question is, what would you do at this point with the data? Just got the mic that can maybe get somebody down here.
Franz Bilbao, I had my training in epidemiology at Harvard, and I have experience with some donor projects, but not many, and I'm not dependent on that. I'm a member of Transparency International, and I just would report back that this project design is a failure, because the donors have to learn that's not so easy. What they think on the table is to be executed in the field. And as this whole conference is about learning, these people, like Bill and Melinda Gates or whoever gets the reports then and see the failure rates, that you perhaps start to think how to do it better next time. And if all people are in fear, like they are in many governments and even now in the private sector, I think then the world is not moving forward.
Okay, thank you. And that was one of the major discussions that we had about, what could be used and what couldn't be used. And I'll tell you in a minute what we did. Other thoughts? Anybody else? Consensus generally to just not use the data? Anybody come up with a strategy maybe that, would use the data in some fashion? Okay, let me go forward. So as we began, I show you again this table of different uses of data that we have looked at, and I think you can see the list as I've already talked about it. But again, use at the site level specifically, versus looking at these data particularly over time or comparing between clinics or developing a formal report. And then in working with some others, came up with a potential scale for the hierarchy of data, where again we look at data that are not usable at all, and some that may be used for a small test of change, PDSA cycle, some that may be used for an internal clinic report, some that could be used for a national level report, and then some used for impact evaluation or publication. And felt that one of the major considerations again here was who's the audience for the data. And so along with the ideas behind the table generated, was the data going to be used just by the team, by the clinic? Would it be used at the district level, the national level? Would it be used by stakeholders and donors? But stakeholders could include providers, the community, and implementing partners. And so trying to parse out a little bit which audiences could use the data even if it really weren't up to standards for another audience. I think some of the other considerations that we discussed were whether or not we could look at changes that would be tested over time successfully for something in the clinic, and whether those would still be okay to use to look at our routinely captured ambulatory care indicators, acknowledging that we would need time and robust data to show improvements in chronic conditions and parameters measuring chronic conditions, and that those would be different when we compare to looking at short cycles for small process improvements. And then, of course, that we would require rigorous attention to data, methodology, and quality for publication. So the big question was, and I think as raised by the gentleman in the front, and one of the CDC monitors said, well, I think you just have to go back out and collect the data all over again. And as you might imagine, the teams weren't happy about that, and the 15 clinics weren't particularly happy about that. What we did is we went back and did collect data on what the actual sample sizes were for each of the three populations, the adults, children, and the PMTCT populations, to calculate what the actual levels of confidence and precision were. One of the criteria that had been suggested was just simply use what's more traditional in an epidemiologic investigation or a controlled trial, which would be to look at whether what was the percentage of the intended target sample, and to come up with a number that could be used as a criterion to determine whether the data were acceptable. And then, as I said, we went back and back calculated, and I think if I can get the pointer to work here, so we had the actual caseload, which you can see here, and the actual sample size. And then this was the sample size that would be needed for a 90% confidence interval with a spread of 8. And those are the figures that we use in the US for our program. And this is the actual confidence level that was achieved using a spread of 8 in either direction, and here with a spread of 10 in either direction. And I think that what you can see is, for the most part, we achieved pretty high confidence levels with the adult population size. So they were either 90% or above, particularly with a spread of 10%. The sample sizes for pediatrics and pregnant women were so low that we knew that we weren't going to be able to use those data at all. So those data, we knew that we would have to go back and repeat the data collection, and I think is, again, learning from the mistake. So at the program level, this has really made us rethink the importance of data quality as part of routine performance measurement for improvement, and how we can best support the countries that we work with to improve the quality of their data. And during our annual program meeting, which just occurred last month, we held a workshop with our data managers to discuss the issues of data quality and develop a program-level improvement and implementation strategy. I want to share that with you here. And I think if anybody has some quick ideas that they would like to share at this point in terms of improvement strategy, let me just open the floor up here before I tell you what the group came up with. And particularly those of you that may have encountered similar situations as you've gone forward with improvement work, what things have you put into place to look at the quality of your data systems? Anybody have any ideas or thoughts, or have some kind of a data quality system in place? Yeah. There's two here. I've got one over here and one over here. Yeah, great.
Very short to learn from pharmaceutical industry. You have, for regional areas, you have a data quality manager who just checks that the data which is coming in is in a good quality and gives feedback, and he gets an incentive and a clear. Yeah, that's so.
Yeah, so a supervisory system then focusing on data quality. Comment over here, was that a hand up there? Yeah. Okay. Can't tell. I think it was somebody taking a picture, so, okay. Any other? Yeah, I can't see, so if anybody can see and got a light glaring. Okay. So I think one of the first things was that, given that we're working with a number of different countries, was just to create a repository for the data quality tools that exist. So manuals, data abstraction tools, quality check procedures, and to create an effective dissemination strategy for these materials to share between the different countries, and to create templates that could be used and then populated to address the issue of different contexts from country to country. To have some kind of a forum where these solutions can be addressed on a regular basis that would capture both existing and new approaches, and then to develop new training materials that address these different issues. And specifically, our teams asked for job aids and wall charts to help teams improve their data quality, and actually want checklists and flow diagrams. And we started thinking about paper materials, and they would like simple things that they would like to see up on a wall to guide them as they're looking at records and abstracting. And that would address things like accurate case list generation, sampling procedures, abstraction, data entry, the quality checks themselves, and the procedures, and to strengthen the tools that exist. To create modular training materials for data quality, things that we will be creating that can be shared amongst the teams. There will be PowerPoints, hands-on implementation exercises, some coaching strategies, some how-to guides and templates in Excel. I think we found that even though we're dealing in resource-limited settings, almost everybody has access to Excel and can use it for analyzing, since they have tremendous reporting requirements for their donors already. And to have a documentation tool for data flow and data quality. So for us at the system level and in our own learning, I think we just found overall that data quality has been underemphasized, and that we underemphasized it, and it's really critical for many purposes, including all of those in the table that I showed earlier. That QI methods can be used to improve and strengthen data systems, and in fact, it's a critical thing to implement an improvement approach to data systems. And that it's important to consider multiple uses of improvement data up front. I think very often, as we're focused on implementing and rolling out, that people don't step back and say, we're also going to use this information later on for other purposes. And whether it's just simple benchmarking to compare across clinics, whether it's longitudinal performance, and whether it's publication, it's very important to think about that up front. That integration of data quality concepts and data use need to be included routinely into improvement work, and that we know that in places that have information systems that are electronic and that are standardized, the data quality takes a huge leap forward, and we should keep that in mind as we go forward and make changes. Our own internal reflections as a program were that we found that the data quality issues that we've identified have been present elsewhere and even in our U.S. programs, and that's prompted us to go back and re-examine very carefully our training and implementation strategies. I think we also found that the willingness to transparently address the problems and manage change in Kenya was absolutely inspiring, that unlike many places back home, that there was an openness to talk about what went wrong and learn from it. And that the understanding of improvement and how data can be used for improvement is often not well understood by donors and requires sustained efforts by all of us to address going forward. So I thank you for your time. That's our Kenya team. As I said, they were very happy to share their experience with you. I'd just like to acknowledge our team members, both in the U.S. and in Kenya, for their assistance in putting this together. Thank you.
Okay, can I ask you all to stand up, please? Just stand up. Hands up in the air, as high as you can. Stretch them out. Okay, hands down. Step to the right. Everybody. Hands up again. Inhale. Deep breath. Exhale. Step to the left. Okay, sit down. Thank you very much. I'm sorry, this is after lunch, and I know it's tough for everybody. Okay, this case study is structured a little bit differently. What I'm going to do is walk you through a real story, something that we worked on, personally I was involved in, and what I'm going to do is this. I'm going to give you the context, the assignment that I had, that we had as a team, and then ask you what you would do. After that, I'm going to share with you what we did, and I want you to reflect on some of that. We'll have another discussion, and then after that, I'll share with you what we're thinking now. So, that's the overall structure. The context in which this is being done. The first thing is that this is being done on a project called the USAID Healthcare Improvement Project. This is a global program that USAID operates out of Washington, D.C. This program is to help countries that are eligible for U.S. foreign assistance to improve quality for the patients that they serve. So we work with governments in different countries to help improve the quality of care. This is a methodology project intended to improve outcomes of care, improve efficiency of care, develop human resources as we're doing that, and many other things, including take things to scale, including create systems capable of continually improving in the countries that we work in. It's probably mine. No, it's not. And this is a project that is the continuation of a series that have taken place in the past. So a lot of work addressing different global health priorities. Let me just share with you this map. We recreate it every year because we're in different places every time. This year, we are in 32 countries. All the countries that have a color on them are countries that we are operating in. So it's a global program working today in 32 places. And the different colors denote the different global health priorities that we're addressing. As you can see, in some countries we're addressing more than one global health priority. Invariably today, we would not work on anything that is small scale. All our work is large scale. It's either districts, several districts, provinces, or national in some cases. Can you imagine what we're talking about? A huge amount of work going on in different places, a lot of knowledge being generated. Now, the technical officer, the program officer at USAID that designed this has been doing this for a number of years, and he has come to an insight that no one project, no one organization, no one government can possibly accomplish this task on their own. So, what did he do? He said, what I would like you to do, and this is what we were tasked with, and several people in the room here worked on this. What we were tasked with was the following: to make available whatever knowledge we know, whatever knowledge we generate through the good work that's happening in different countries, available not only to our teams everywhere, but to anybody in the globe so that people can learn from that. Can you imagine if that were to happen, how much that would improve care all around the world? You can be sitting anywhere in the world and you want to know something about how to solve this problem. Somebody at the other end of the earth has solved it. And our job is to make that knowledge available to you so that you can take it and work with it. It's beautiful. So we set out trying to accomplish that task. Okay, let me ask you a question now. So this is question number one, probably. The first question that I have for you is, given a context of this sort, an assignment of this nature, make available whatever knowledge you generate on what works, what can make healthcare better. What would you do if you were in our place? What are the sort of ideas that come to your mind? Please, give me some ideas. What would you have done if you were in my place or in this team's place? Come on, we did do an exercise. Okay, who wants to start? Please, John.
You need to know what information...
Microphone.
You need to know what information is already out there and available, because you don't want to duplicate something that's already been done.
Information that is out there available so that we don't duplicate. How would you do that?
I mean, the easiest access is web-based access, so you do internet searches, etc. You look at common sites and linkages between them.
So, Search, find out, make that available. Great idea. Another idea, Laura.
Create some kind of live wiki where the person asking can just put the question out there and get responses.
That's a great one. We didn't think about the wiki. Thank you. Another idea. Please, Charlie.
It seems to me you need a librarian.
Librarian. Very good. Librarian. We call it documentarian, but that's good. Okay. Next. So imagine we have websites, we have, 10, 20, sometimes 50 people in the country working on this. What would you do? Please.
Well, I was thinking you're interested in countries where they're not going to have computers on every desk, so you probably need to pick up the phone and, if you've got contacts in those countries, and find out what's being done that's not easily available on the end of the internet.
Excellent. So where there's no internet, pick up the phone and get the information. Other ideas?
Ask your recipients. I mean, you have really, really intelligent people. They might not have internet. They might not have all the resources that you do have, but they're bright people and they might know.
Explain what you mean by recipients, please.
The recipients of your aid. Go to Honduras and ask the people there, the healthcare leaders and the patients, what would make the biggest difference to healthcare delivery in that topic in their country.
Great idea. Other ideas, please.
Just to evaluate political context, all the, how do you say, what the country context.
What about the political context? What would you...
Economic and politic.
So how to make improvements in these political or economic circumstances? Great idea.
Consider what information you really want to share that's useful. So, for instance, lists of what people did is not nearly as useful as how they did it. And then when we share that, what are the ways, many ways we can share it? Can we share it electronically in stories? Can we share it in peer-to-peer training examples? What is it we want to share?
Okay, so I'm hearing now something that's distinctly different. Not just what happened, but how it happened. Great, we have another idea.
Yeah, thank you. Identify actually your stakeholders from civil society, from the government and from the private sector and use them as entry point for specific information, and then probably also cluster them regionally, so that might assist.
That's great. I wish somebody was recording this. Okay, another.
What I think that would be very helpful is if you had a big database where countries are on district level, context, wealth, and all this information, bring it together, and also the policy that the country or the district has. And then you can see what intervention works in a special context. It is culture, it is religion, it is wealth, it is a lot of this. And we know a lot of these items. And we can, if we bring it together, we can do great research.
Great. Can we go back to another question that was another answer we had? How would you do that? Erica, can we stay with this one? How would you do it? You said what to do. How would you do it?
Well, there's a lot of information available, actually, but it is spread over the world. And there are these inquiries where people go into a country, they have their questionnaires, and they gather the information, they make their report, and then the research is finished. But if we would bring that all together and put it together, and we have a lot of information.
Great, thank you. As you can see, okay, one more, and please.
So I have a suggestion of appealing to the crowdsourcing ideas and trying to use a media that we don't often talk about, but that appeals to a large percentage of the population, and that would be TV. So I'd propose a a reality TV show in which you take dynamic, attractive people from NGOs in each of the countries, and they compete. They present the ideas in a dynamic, exciting way in a competitive environment, and people from the country vote with their cell phones, which most people have, and then you take that internationally and use that to generate and test the ideas by the people who will actually get it, the people watching their TVs.
I love it. Can we talk after the session? Okay, let me take you through a couple of, there's plenty of ideas, but let me sort of share with you what happened. So the first thing that we thought about, and I would imagine most people would do, and several have sort of said it, well, let's create a medium. So we set up a knowledge management portal. We asked Johns Hopkins Center for Communications Programs to design it, work with us. They designed it, it's state-of-the-art. And this is what it looks like, www.hciproject.org. You can see it today. And what we started to do was to populate it with the things that we had. You said something about gather the things that we know about. But also, in addition to that, what we did was we created a space where anybody from anywhere could add stories. Now, we didn't go down the route of, places that are not reachable by the internet, go and talk to them, because a lot of the stories we were gathering were either from our own staff, so we did have direct access to some of those, and there are many thousands of people that are working with us. But we also reached out to partners that we know and other people who are in the world of improvement and asked them if they would submit some of their stories, etc. And this is what that looks like. So it's available. If you have a story, please submit it. The other thing that we did, which was very interesting, was we went down the route of a database type of thing. Now, we didn't want to complicate it too much, so we used an Excel setup as well as a journal. And you can see that it essentially considered a place where you could enter information, tell the story, enter the data, annotate where things are, describe the changes, and the like. So a lot of what we call the standard evaluation system that would standardize the way in which we're collecting the data so we could make sense of it and make it available. Now, that was tested in several countries. I believe it was 8 countries, right? And how many? 6. 6 countries. And then we went out and said, well, let's test this. Let's see, how did it work? Let's get some feedback. And we did a proper assessment of where things are and how things worked out. Well, we learned a lot from it, and we learned about some of the things that were good, some of the things that were not. Now, the biggest thing that struck our attention was the fact that even though we thought it was so easy, and it's a journal, it's an Excel database, etc., people need to collect that data anyway, people were saying, it's really difficult for us to just enter this data the way you want, describe the changes, record all of this. It was not easy. That's one piece of it. So the part where we're trying to get the information seemed not to be as easy as we would have liked it to be, and as we originally anticipated it would work out. What's the other piece that didn't work out as well? Can you imagine? Who would like to take a guess? Okay, how many people are accessing it? Some are, but not as many as we'd like to see access. How many people are inputting their own stories on the web? Some, nothing like what we'd like to see happen. Now, that made us think about, okay, what should we do? We've, in a way, done the normal things that people do, which is emphasize the collection part, collecting the information. We've put it out there for people to use it, people to give us more. We really didn't get what we were hoping to get out of it. Let me ask you another question now. Given this, you've gone through the experience, it's been a couple of years, you've put a lot of effort into it, very smart people worked on it. And it didn't really, it's good, it's not, but it's not what we want. What would you do? Please. Microphone, please.
I'd offer some financial inducement, a prize of $100 for a good story.
$100 for a good story. Please.
Just ask to people who you want to be involved, what they are able to do.
What they're able to do.
Yes, what they want to do for this, just...
Well, actually, maybe this is a place where I should interject. So the people that we're asking, for the most part, are our staff in the different countries, and what they have to do is to fulfill the statements of work that they get from the USAID missions that authorize them to do this work and pay them to do it. So they actually have improvement projects underway, and what we're asking for is give us the data that you're using to show improvement. So why isn't that coming through? Oh, sorry, please.
I think you need a few demonstrations that this information really helps people to improve their own project.
That it helps this information.
And then
do you want to elaborate a little bit more on why would you doubt that this information helps?
It has to be demonstrated first. It was like the quality management movement took off. First you have to have some few demonstration projects that this information is useful actually. So you have some case stories and you make, of course, a social movement out of it.
Okay,
case
studies and then you make a social move. Okay, we'll talk more about that, please.
Yeah, if I was the one at this particular moment, I would carry out a cause-effect analysis on each of the intervention and find out why it didn't work, and then I can go ahead and design other interventions.
Thank you. Other ideas?
Why not a meeting? Just make people meet and speak and just express.
Tell me more about that.
And just tell stories. Just tell.
Tell the stories.
It's oral.
What happens when people meet and talk? What's the difference between two people meeting to talk about it versus one person writing and the other reading?
The exchange, I don't know.
The wonderful, thank you. Who's next here?
Instead of asking us, I would have asked them why they weren't filling it in. So go back to your people in the field and say, this is online, why aren't you filling it in? And ask their views. If they're too busy or they don't know how to put it down or they're sensitive about their data, ask why they're not doing it.
It's interesting because when we did, that was part of what we did, and their response was, we have a full-time job here. We've really got to do the work we're doing. This is like on top of what we're doing. So a lot of them felt that this was over and above what they really were trying to do.
To me, this is about relationships. So there isn't a relationship between the centre that's trying to get the information and where the information is coming from. It's touching on one or two other people have said it's about purpose and ownership. And I think it's about conversations about why would it be important to the person to give information? Why might it be important? Someone then to gather that rather than asking them to do it. But from that conversation, you could actually gather the information in a usable form. But then continuing that, because if you're starting to get that engagement through conversations, then it's about what they want back from it. Because actually they may be the people that want information from other sides. So it's about building that bidirectional, mutually constructive relationship.
Thank you. So I'm now hearing several people say the same thing, that it's really about what people need and what a conversation brings to that end.
I visited your website, and one of the things I thought about was the form. The thing that gets out to the front line is for highly educated people. It's not easy to understand. In my experience with my partners, it hasn't been easy. Maybe it was an idea to make some sort of pixie version of the
What's
reports.
A pixie version?
A short, in a language that's very down to earth and in a language that you understand every day, and that so that you can also start these projects bottom up instead of always going the other way around.
And that's been my experience, that it's very difficult to use this because it is information on a high level.
Thank you.
Just as in Dr. Agins' talk, you've both described an extra burden of measurement. And if we could find in both instances a way in which people could fulfill two tasks at once, I think we'd win. So in the data collection task, if it was just part of the routine care of the patient that the data fell out of the record, maybe be very difficult in the setting that you were talking about. And in your setting, if it was possible to submit a report to the funders, to government, by filling in the quality improvement report, rather than having to do an extra report, that would make it just part of the routine job rather than something extra.
Thank you. Others?
Rashad, remind me if you have gone after the people who might use the site or the knowledge and what they're telling you about how they might use it. And the reason I'm asking is that I've built something with thousands of things in it, but we're finding that people are too busy to go seek it out, and now we have to figure out a different way to help them know what's there, because so far the searching really, it's really not working the way we envisioned.
Right. I think we sort of have that experience, and I know that one of my colleagues, the Director of Knowledge Management and Communications, has been trying to get at that. Whether she's homed in on the answer to it, I'm not aware yet. And I don't see her in the room to be able to answer it. I don't know if...
Yes. I work managing a network of almost 50 organizations working in Zambia. And in order to get them to participate in some of the events or gathering data, I always have to involve them in everything that I develop. So I think it would have been a good idea to involve them on the design of the website and the materials as well.
Thank you. So, please, I think we have one more. And I can share with you some of what we've done.
It seems as if you have a big Excel sheet that nobody can read, or they could read it, but they don't. And that also you're not talking to the heart of the users, but to their mathematical mind.
Yeah.
If this should be useful, you have to speak to their hearts or to their center of energy. You have to put meat to the bone. You have to add flavor to it. So somebody has to tell a story at some point, so that people would see what is behind the data and how it's affecting them in their work.
It's a very interesting idea. So that form was designed primarily for staff members of ours in the different countries, and of course their hearts are very much in the work. But that I like the idea that it should appeal to them. So let me share with you, one of the first things that we did is we realized that complexity doesn't yield better results, so we had to simplify some things. And this is the one thing that we are pretty sure of now. We've simplified what we're collecting. So essentially we said for any one team working on improvement, there are three things that we want. We want you to record what changes you're making. We want you to put them on your time series plots and annotate when did you do what at the level of a team. And then share whatever you're doing with the others in your collaborative. Essentially the very basic thing that they should be doing anyway, but let's systematize that. Made it as simple as possible. If we request less than that, basically they're not doing their job. So that's very much in line with a lot of the feedback you've given me. The other thing is we said at the program level, so now we're talking about, for example, a whole collaborative in a country, what needs to happen? Well, the first thing is we do need to keep a record of the changes tested at different sites. So if you've got 50 sites, you need to, for each one of them, maintain. These are the things that we've tried here, there, and in different places, and then look at the results, aggregate them, see what is working and what is not, share them within the collaborative, and then make them available so that we can share them either with other people in your country or in your region or globally. That's on the collection side. So one thing we became much more sure of is the need for simplicity. And I think that's one thing that we have sort of already, I would say, accomplished. Now, the next thing was there was an insight that we developed in terms of what's going on outside of healthcare. And let me share this with you. We haven't worked this out, but this is where we are today. We're on the verge of developing our strategy. But let me go through some of the things that we're learning. First thing is, there's a myth about knowledge management which says, build it and they will come. That is, develop the website, put the information there, people will come and take it. It's a myth. Other industries have learned that. It's about time healthcare did. We're starting to learn. The second myth is that technology can replace human interaction. Not true. There's a lot of value, and many of you here are talking about it. Technology does not replace human interaction. Second thing is, there's something, and somebody also mentioned it, explicit versus implicit knowledge. The knowledge that we write when we write a report is explicit knowledge. If somebody asked me to write something, I will go through, For somebody else who's implementing that work and needs help, all that I'm talking about is probably not what they want. What they want is what's called tacit knowledge. Knowledge that generally doesn't get written up in these types of reports. That knowledge is really generated through conversation when people are talking together. And that's very much what you're saying. It's the value of the human conversation when we get down to talking about it at such depth, and then you ask the question that's most relevant to you. In fact, if I were answering you, I would only generate that thought when you ask me the 1, 2, 3 series of questions that get me there. That's the only time I'll generate that idea that then for you is not information. It's real knowledge, tacit knowledge that really helps you. That's something that we've gotten to realize that is very much known in the area of knowledge management and is actually practiced outside of healthcare. The other thing about technology is that technology cannot make it happen. It can help it happen. And there's a big difference between the two. So today, we're really not thinking of the website, the portal, these things as the things that make knowledge happen. We're saying, how can we use them to facilitate the human interaction that generates the knowledge that person X, way out there at the end of the earth, can get from somebody else who's doing similar work in this place right here. I would say that if I were to sort of, what is the direction we're going to take on this? And we haven't done it yet, we're about to embark on this. It's no longer emphasizing collecting the information. It's more about connecting the people so that they can generate the knowledge they need that helps them. I'll stop here on this. I think we have 5 minutes left for general questions and answers and summarizing. Please.
Dr. Massoud, I'm very impressed with your work and your energy. I'm Dr. Milikovsky. I'm a member of the IHI Patient Safety Activist Group. I was wondering when you would consider maybe assisting a country which is persistently last among industrialized countries and fits smack in the middle of what is called underdeveloped country between Slovenia and Costa Rica. You see which country I'm talking about?
I'm not quite getting it. No. Which one?
The United States of America.
Oh. Was that a question? That was a comment. Please, any other questions or comments? For all of us here, not just knowledge management. you want to summarize?
No.
Wrap up.
Yep. Well, thank you very much, everybody. I really appreciate your coming and participation.
Thank you.